So hi, I'm Josh Epstein. I want to talk about agent-based computational modeling in public health, infectious disease largely, but also things beyond infectious disease. It's talk about models, but it's also talk about modeling, and part of the message is to just be courageous and build models, and I'd like to communicate that in addition to the specific models I want to talk to you about. So the talk is called Agent-Based Computational Modeling in Public Health, From Playground to Planet. So I want to show you that this type of modeling can be done at a whole variety of scales, about a whole variety of hazards. I'm a professor of emergency medicine, although I have a PhD, not an MD, which at Hopkins means phony doctor, PhD. But I run a center for advanced modeling that involves the whole university. It's a very interdisciplinary place, but one of the central methods is agent-based computational modeling. How many people have heard of agent-based computational modeling? Don Burke, good. It's a start. It's a start. Okay, well the idea, it's a powerful way to model all kinds of complex dynamics on computers, not just infectious diseases, but things like revolutions, migrations, financial crashes, all sorts of things. The basic idea is really simple. You just build artificial societies of software individuals and let them interact on whatever landscape is relevant and see how things evolve and try to generate the phenomena you're interested in. So one deep idea about the whole thing is that what do you mean by an explanation of social dynamics or social patterns? What you mean by an explanation is a micro world that suffices to generate that pattern when you unleash these agents into an appropriate interaction space, okay? But basically the idea is we just build artificial societies inhabited by diverse individuals or agents, each of which is implemented as software. So a picture's worth 1,000 words. So here's a really simple agent-based model of an infectious disease on a playground, okay? And you'll see a green playground show up here. And there'll be blue agents are healthy, red agents are sick. They're going to move around. When a red agent bumps into a blue agent, she gives them the bug with some probability. After you've had the bug for a while, there's some probability that you die. That's it. Okay, that's the whole picture. We start with 2 sicks, everybody else healthy. Here they go. So when you die, you leave the landscape. You could say you go to the infirmary or you die, but I like to say you die. So the disease is spreading. And we're rooting for these blue kids, but it's not looking good. Go. Sorry. You know, sorry. Good. Empathy is an important thing for modelers to have. All right, so the idea here is you can see what happened is that basically everybody was susceptible at the beginning, except a couple of these red creatures. And because everybody got sick, people were transferring from the susceptible pool into the infected pool, and then people were transferring from the infected pool into the dead pool. And if you look just at the incidence curve, which is something we care a lot about at Midas and in public health generally, it's got this very characteristic feature, and it looks like a lot of the epidemic curves you see in data sets where everybody's mixed nicely like in a playground. So this is an example of influenza in a boys' boarding school in the dead of winter. Everybody's shoved together. They're using the same spoon, if it's like my son. And you get a very good fit to the classical models of epidemiology. One of which is this very classic Kermack-McKendrick model. Who's heard of that? Okay, Dahan again. All right, so I'm going to go through really quickly. This is just we're not going to down here a whole lot. Because my main message is this isn't going to hold up when we make things a little more complicated. But the idea here, this is the curve we got with our little playground. And the idea of the Kermack-McKendrick model is that the rate at which susceptibles transfer into the infected pool is proportional to the product of the susceptible population size and the infected population size. So people transfer, susceptibles become infected at a rate, beta is the transmission rate per contact, and SI is this very perfect mixing type of contact process. and then everybody dies negative exponentially. But SI is the real point of the model. And why is S times I perfect mixing? Why does that mean perfect mixing? It means perfect mixing because if you took every susceptible and lined them up in a row, and every infected and lined them up in a row, and then one by one, every infected sneezed in the face of every single susceptible, that would be S times I contacts. And that happens every delta t, every infinitesimal time period. And that's why the differential equations look like this. di dt is beta times Si. It's perfect mixing with transmission beta each time. All right? And that works very well. Then one of the beautiful things is that this showed that epidemics are threshold phenomena. But maybe we can come back to that. I feel like I'm not moving quickly enough. So for a perfect mixing situation, like everybody shut up in a boys' school in a box, that kind of modeling is great. But what if it's something released on a metro system or an airport or an international airport? The well-mixed models are just going to be misleading. They're not, it's not, love idealizations. Idealizations are really important. The whole point of modeling is to idealize, but you have to idealize in ways that aren't outright misleading. And if you imagine the spread of a pandemic across the international transportation system or smallpox in a metro system, a well-mixed model will take your attention away from strategies that are actually important. And one example is work that Don and I did, and a number of other people on smallpox, and I'll show you that in a second. But agent models are very powerful in capturing the spatial fine structure of direct social interactions, networks, heterogeneous populations, and importantly, behavioral factors that are pretty much missing from the Kermack-McKendrick model. So I want to show a variety of these creatures moving up in scale from the playground. First to a county-level smallpox model that Don and I and Derek Cummings and others developed really in the wake of 9/11, although Don and I were working on smallpox before 9/11, fortuitously or not so, whichever. And at the time, there was a big debate about whether there should be mass vaccination or something called trace vaccination, which Sarah touched on. Mass vaccination is the idea that you just give everybody a smallpox shot. And that has the risk, the downside, that the smallpox vaccine is a live virus and you can have a terrible adverse reaction to it. If you're HIV positive or on chemotherapy or severely immunocompromised, you can die from that shot. And even if you're not, if you have acne or psoriasis or eczema or diaper rash or other things, you can have a terrible reaction. So you don't just blithely vaccinate 300 million people. The other alternative is trace vaccination. The idea there is Don walks into the emergency department right here, and he's diagnosed with smallpox. We track down everybody with whom he's had contact in the last 6 days. We give them a shot. Problem, who the heck was that? I mean, we don't know who you were in contact with for the last 6 days. It works. It worked in rural, India in the smallpox eradication, but it won't work now. So homework for us was think of an intervention, think of a vaccination strategy that isn't mass vaccination, because it's too dangerous, and isn't trace vaccination, because it isn't practicable. So we figured, let's build a model and start to dig into that. And the idea was, okay, so what scale model do you build? And we decided to build a model. Einstein said, make your model as simple as possible, but no simpler. And I think we found the sort of sweet spot in that connection. We decided to just include social units that loom largest in the data on smallpox, and we had a lot of data. And those turned out to be homes, schools, workplaces, and hospitals. And so we built a little two-town county because we cared about commuting. And I'll just show you the idea. And this is an example of a very toy model that nonetheless had a lot of influence in actual policy, precisely because it was simple, people could tell what was going on, and it suggested a novel avenue. It wasn't the last word, but it suggested a new approach, a different angle, and models that aren't predictive or accurate or detailed can be very important in that respect, and more important than a detailed model, because the detailed model, the guy will say, I don't know what's up your sleeve. Here's a simple model, you know what's up our sleeve, and it's telling you something interesting. All right, so the idea was two-town county, 100 households in each, square town and circle town, Here's Square Town, here's Circle Town. Every household is a little two-parent, two-kid household. I'll show you the US national model, which has everything census correct and all this. But if we're just saying toy town, two parents, two kids, two parents, two kids. Here's Mr. Green. The epidemic's going to start with this Circle Town guy. And at night, everybody's home, tucking in their kids, doing what they're doing. In the day, everybody goes to work and school. Some people from Square Town work down in Circle Town, the Circle Town workplace. And some people from Circle Town, like Mr. Green, work in the Square Town workplace. Kids go to the school of their own town. And some people work in the hospital, which is common to both towns. All right? So it's really simple. Every day they go to different random locations. They go to work, but they don't bump into the same people every day. So at night they're home. Day they go to work. Night, day, night, day. All right? And on it goes. All right? And you could throw any bug into that circulation dynamic, and we were interested in smallpox, and we've published a number of articles on this in which we get into great depth on all the details of smallpox and its natural history. But for purposes of this sort of policy level modeling, it proved sufficient to just have a couple, just 6 states. So we're going to just color you by your state. Blue, you're healthy. And we imagine you get infected on day 0. Then for smallpox, there's roughly a 12-day period in which you're infected but have no symptoms and you're not contagious. Then you become infected, you get a throat rash, oropharyngeal rash, and you can spread virus respiratorily for, people debate this interval, but we've been thinking 3 days or so. Then you get really infected and have the distinctive macular rash and shedding virus aggressively, and you're very contagious, but you're not very mobile. You have that for a while, and then you die with probability 0.3 and live with probability 0.7. So it's a very deadly bug. And the vaccine efficacy thing we can come back to. That's the basic idea, all right? So here's a base case run of this model. No policy interventions, no background immunity. One Mr. Green index case starts the epidemic in Circle Town, and here's how things unfold. Again, this is one. Here's Mr. Green. You see him? He goes to work. Here he is at work. Comes home, yellow, infects his wife. She works up here too. They infect one of their kids. This starts to spread in schools. And the thing goes on. Now he turned red. He's very sick. Goes to the hospital. Does he make it? Come on. Oh. How fun would that be if you get it's like a blue kid? He goes to the morgue. It's the morgue. Oh, sorry. You want happy stuff? I'm the wrong guy. That's right. So this thing goes like this. Okay, and after a while, pretty much everybody gets it, and a third of them die. White ones are immune and go back to circulation. All right, so this is one realization of a stochastic process, okay? If you did a different set of random numbers, you'd get a different history of this county and its epidemic and so on, all right? Okay, so we use this model. One of the nice things about agents, by the way, is you can produce what we call dendrograms of these epidemics. So I really know who infected who and when and where and what were their attributes. And sometimes you get people who spread a huge amount. You get a huge amount of spreading from a few people. So what is it about that guy? I mean, if you have 6 shots you could give, who would you give them to? You'd like to know, what is it that makes this person a super spreader? The colors are for different types of smallpox, but he's a big spreader, he's a big spreader, and we can reconstruct the actual spread dynamics. And we can do this lots of times and see if we can develop some statistics that would help us identify who are the super spreaders. What are their attributes? Is it their location in the network? Is it their biology? What is it about them that makes them special and worth going after early? All right, so this run, you get this this is the incidence curve. It's kind of like the classical curve, except it's kind of bumpy and lumpy, and there are a bunch of reasons why it's that way. But we thought, look, let's figure out what's a nice vaccination strategy. Again, not mass, not trace. And we said, let's look at the data. We had all this data, as I said, and we looked at all European smallpox, really in the 20th century. And we were looking at the percent of transmissions in these different locations, which I mentioned are the ones we have in the model. And we tuned the model until it matched the data. That's basically what we did. And if you look at the data, it says, look, 50% of the cases are transmitted in hospitals. So let's vaccinate all hospital workers in the first place. Just take that transmission line out. Then another 20% or so are household members. So we said, what happens if you just preemptively vaccinate all the hospital workers and then reactively vaccinate family of cases? I can't track down every contact Don has, but I can track down his household, and I zap them. And it turns out if that's not mass vaccination, because we're not vaccinating everybody, it's not trace vaccinations, because I'm not really tracing, I'm just saying get household members. And compared to the no intervention case, that takes a big bite out of this epidemic, right? It's not a prediction, it's not a perfect, replica of anything, but it's an interesting idea that you wouldn't get, probably, without some modeling. And this was an important function that a toy simple model performed in a setting fraught with, emotionality and uncertainty, and it's an important topic. And as I say, one of the reasons the work was influential was precisely because it was simple. We did it, we involved the policymakers in the model building, so that when the thing is done, they've signed off on all these assumptions. We asked D.A. Henderson, a very famous Donald Henderson, one of the really important people in the history of smallpox, directed the eradication effort and so forth. So we say, look, we're trying to build a model. Somebody gets sick. How long are they going to move around? And he said, basically 3 days and they're out. So okay, we'll build that assumption in, and you can at least appear credible to the actual client of the modeling. And then when you come up with something counterintuitive, they pay attention to it. If it's a monster model, they don't know what's going on, and you come up with something counterintuitive, they don't want to run any risks about it. Okay? So there's a role for simple toy models. So we did playground, two-town county. I want to shift gears because I show another scale, but it's a different type of modeling. This is modeling of a city scale toxic chemical release. It could be anthrax or something else. But this is a model. I'm going to cut to the better model, which is Los Angeles. So here's a three-dimensional Los Angeles. And you're going to see a plume of, this is going to be a neutrally buoyant plume, phosgene or something. And it's going to go through LA. This is all traffic color-coded by velocity. And the plume is coming along. The purples are the slowest velocity. So if everybody pours out of these buildings in downtown LA and jumps into the street, one person per car, you get this massive congestion, and exposure rates are very high in that case. So you want to use this tool as a kind of evacuation design optimizing environment where you can develop, what's the right ratio of people who shelter in place, who should shelter in place, who should leave, when they leave, where should they go, is there some sort of traffic-aware routing you can do? So there's a whole suite of interventions that you can think of to anticipate an airborne toxic contaminant, biological, chemical, radiological, whatever it is. And the computing is so vast at this point, we can do this on such a scale that you could pre-compute, billions of these runs. The actual dynamics are very nonlinear. Navier-Stokes equations, I don't know who's done any fluid dynamics, but the way things unfold depends heavily on the release point, the release volume, the wind conditions, the time of day, the temperature, all this stuff. But you could pre-compute 100 billion of these situations. And then if something does happen, it's a petabyte playbook from there, right? You go to, this is what happened, it's play 4,327,C, And that's where I begin my real-time, activities. Here are a couple more views of the same thing. Upper left is looking down as we we saw before. Upper right's another view. Lower left, you're looking down on the plume with all this traffic. And in the lower right, you're tracking exposures, number of people exposed, and average exposure level in parts per million per second. So if you were interested in something like what's going to be the demand for emergency resources, that's going to depend on the toxicology of the substance and the exposure levels and so forth. But you could get a good handle on what are we looking at. Okay? So this is an example, another example of modeling. This is a totally different kind of model than a toy model, right? It's legit, serious atmospheric physics with traffic modeling and adaptive behavior and fear, and I don't want to take that evacuation route because I want to go across the plume and get my kids at their school. But what do you have to do to tell people, trust me, they're okay? You know, when all cell phones are clogged and everything else, right? So there's a whole risk communication component to this game. So here's another example of the same thing where you're coupling legitimate physics with this Gucky agent-based modeling underneath, okay? So there's legitimate atmospheric physics for the plume, and then traffic modeling and behavior and risk and so forth underneath. Play the same game with all kinds of disasters. Here's work we're doing with civil engineering at Hopkins, which is earthquake, and here's literal structural dynamics. On the right, you're looking down on the top of these buildings from some dizzying height. Some of them do very badly under this seismic pattern. The upper right one collapses. And they're doing fascinating work in structural engineering on how to make buildings fail, but not fail deadly. They're allowed to collapse, but in ways that permit egress, which is a very interesting line of engineering. But you can consider this as a behavioral model also. Here's a net logo rendition of that, which is 12 blocks. You're looking down on 12 blocks. The colors are different buildings. And these are people trying to leave the buildings. And we can have ambulances and rescue vehicles, and the totals able to evacuate are on the upper right. Anybody who wants to start agent-based modeling, go to the Net Logo website and do the tutorials. It'll take you an afternoon. Net Logo, Netlogo. Just download it, do the tutorials. They also have a huge library of models that are fun. The applets let you interact with the model, change your assumptions. That's definitely the way to get into this. Okay? All right. And again, I think the novelty of that work is that it's this synthesis of applied science, fluid dynamics, tornadoes, earthquakes, heat waves, what have you, and behaviorally credible agents. And you try to understand the feedbacks, nonlinearities, self-organization, and so forth, and design optimal preparedness and response. So back to infectious disease, much bigger playground now is our large-scale agent model. It's not our largest scale model, I'll show you in a minute, but this is the national scale model. This is published in TOMACS, Transactions on Modeling and Computer Simulation, which is sort of the journal of record for high-end, high-performance computing. And this is a synthetic United States with 300 million people. They're correct by US, they're calibrated to US census data for age, gender, household size, workplace, income, what have you. They move around a space with 30,000 different zip codes. So every zip code in the US is included. So there's a giant, in principle, there's a giant matrix that says if I pick a person from zip code I, what's the probability they'll go to zip code J? So there's 30,000 by 30,000. It's a 900 million cell matrix of movement probabilities, which is not, not something you manipulate in your head. So that's all calibrated into this model. And again, we did a lot of work, Midas has done a whole lot of work on H5N1, H1N1. And one of the runs we did for swine flu, just as an example of how this works, I'm just going to color code agents black if they're susceptible, red if they're exposed or infected, and blue if they died or recovered, because whether they die or recover depends on the case fatality rate, and as Sarah would could talk about at length. That's a very hard thing to estimate, particularly when public health and surveillance systems are lousy, as they are in places like Thailand. All right, so here's one run. We start the thing in LA. This is about a 250-day epidemic. And again, this is the no intervention case, and you do all sorts of work on antiviral drugs, vaccine priorities, close schools, close workplaces, social distancing, and look at lots of different mixes of interventions and see how they perform in reducing morbidity and mortality. The big thing about that is that it runs in about 10 minutes. I mean, it's the fastest national scale agent-based model that we know of, and it permits you to do things in near real time and to do all kinds of, all kinds of very important explorations on the fly, really. The biggest playground I'll show you today, though, is the planetary model, which is we call it the global scale agent model, which I believe to be the only literally bona fide agent-based infectious disease model. It runs 6.5 billion agents, all distinct software objects that can make decisions and change what they do. And again, this is just a standard, this is an article in Nature talks about this, but this is also discussed in the Tomax article. So here's a spread with no intervention, whatever. Again, these are all single realizations of a stochastic model. This is another about 300-day epidemic. So if nobody does a damn thing and continues going about their business and continues their contact practices, the thing's not gonna, you're gonna be in trouble in a hurry. So SARS was on 5 continents in about 24 hours. So, under modern conditions, things can move. I mean, when you compare that to 1918, I agree that the medical background is a lot better, but the transportation background is a lot better too. So I don't know how it all nets out. It would be bad, okay? But you can also look at, okay, so what if you ban all long-range air travel? Same epidemic. You buy yourself a whole lot of time to do things like develop vaccine maybe, or distribute antiviral drugs, or take social distancing measures, or other sorts of things. But the point, I would say the meta point, and maybe the more important point is, if somebody comes up to you and says, okay, pandemic flu might break out in Thailand, yes or no, does it make sense to introduce long-range travel restrictions? I mean, you just can't think about it in an orderly way without models. So whether they're predictive or explanatory or perform other functions, they impose order on an important discussion fraught with uncertainty. And that's an important function of models. And particularly in cases where we worry about these bugs that haven't turned into human-to-human transmissible variants, there's no way to think about that ahead of time without modeling it. So an important function of models is to permit us to imagine and explore preparations for things that don't even exist yet, all right? And to study these big, messy problems that you just can't get your brain around sitting around a table. You've got to have some model to discipline the dialogue about preparedness and so forth. Okay. There's an important gap in a lot of these models, which is behavioral adaptation. Contagious fear, distrust, norms, all kinds of cognitive biases, conformity effects, network effects. These all influence how things actually spread. And I think it's fair to say that Midas has really taken a lead in emphasizing the importance of behavior and in trying to get our models to incorporate some type of behavioral realism. So just examples. I mean, there's a paper I wrote with Derek Cummings and others called Coupled Contagion Dynamics of Fear and Disease, which looks at a lot of examples of contagious fear and how the role it plays in things like vaccine refusal, non-adherence to medication regimes, breakdowns in social distancing measures, distrust generally. So we want to get behavior into these models in a credible way. And one of the first, I won a prize to do this. But one of the things we developed is this coupled contagion model. And the idea here is there's 2 epidemics. One is an epidemic of disease proper. The other is an epidemic of fear of the disease. When the fear goes above some threshold X, you go to the basement. You duct tape yourself into your basement. and you're out of circulation. Then when your fear falls back below X, because you've become complacent or you think things are better, you come back into circulation. So the disease affects your fear, the fear affects your contacts, that affects how the disease spreads, and you get these cycles of epidemic and behavior and feedbacks and coevolution between the two, and you can generate multiple waves, including the 1918 multiple waves, for which we didn't have. This may still not be a good explanation, but it's a different explanation. And the idea here was, this is I think I probably got this from you, Don. Chicago Tribune. This was when the epidemic was almost over. So you get these multiple waves, okay? And the reason you get the multiple waves is, as we saw in the case of smallpox and these other things, it only takes one case to really get these things rolling. And what really matters is the level of susceptibles. It's how much fuel there is, not how much embers there are. So the idea is, this is the Chicago Tribune. They thought the thing was over. They said, if you want to dodge the flu and the pneumonia, Chicago's the best place to be in. The epidemic here is over. Chicago's the safest place. We're practically out of the woods. All bans are off. In a few days, I'm sure I shall again be justified in stating that Chicago's the healthiest city in the world. And writing in 1918, before the Kermack-McKendrick equations, before people understood the threshold nature of epidemics, that seemed sensible. You look at it and say, gee, nobody's sick. There's very few people sick. So the heck with it. Let's everybody go back. But the point is, if there are even a few people sick, you're pouring fuel on the fire to send susceptibles out there, and that's why you get these recurrent waves. And we can come back to that mathematical proof that there are threshold relations and herd immunity and all of these things have a nice basis in these classical models. Yeah, they'd never have made that mistake if they'd had Midas. So, all right. So another way to get our teeth, some variety of ways to think about this behavior stuff. My center at Hopkins is doing two separate analyses of Twitter feeds. We don't do as well as Google Flu in predicting incidence, and that's under review at NEGM. But more important, it forecasts attitudinal dynamics, because we care about the behavioral dynamics, not just the disease dynamics. So we've found nice ways to filter that data for what we call concerned awareness, and we'll present a couple of those efforts at Midas using a 10 billion tweet data set for the 2009 swine flu. And the idea here is not just to predict incidence better, but to use these techniques to parameterize the behavioral models. So we're building diverse models at a variety of scales for diverse purposes, some to just impose order on sprawling, messy, important problems, to design novel interventions, to explain data, and for diverse audiences. And I thank you for being one of those diverse audiences. So I welcome follow-up. Please feel free, I'm serious about this. I mean, you have my email, you have my phone number. Give me a call, shoot me an email, and let's continue the conversation, okay? Thank you.